good evening, and welcome to the Caring View, the online health and social care platform, free to access to absolutely everybody. Before we get started, don't forget to hit that like button, hit that subscribe, follow us on YouTube, Twitter, or X, or Instagram, or Facebook, or LinkedIn, or you name it, we're probably on there. Before we get started, www.thecaringview.co.uk, that's where all of our free resources are. We are discussing the CQC tonight. We have got some new free resources up on there. If you've ever thought to yourself, oh, I could just do with some quality statement posters. Well, what do you know? We've got them on the website. Go and download them for free. Available in PDF, JPEG. Download them, do what you want with them. We don't care as long as they are useful to you. We do everything for free. There is no cost to anything we do, and we only are able to manage that through our fantastic sponsors, and I must give them a huge shout out tonight. So we have Prosperwell, the UK's leading digital marketing agency, www.prosperwell.co.uk. Please do go check them out for all of your marketing needs. CBAT, Care Business Associate Training, really good resources and training on there. I'm actually looking at the CHAPS course that they do. Really cost effective compared to a lot of them out there, and I've researched a lot of them, so please do go check out CBAT, and I'm talking from a professional point of view. I recommend them, they're great. And also Attis Care by Attis Insurance Brokers for all of your comprehensive care coverage and proactive risk management. Good evening, Mark, and how are you?
Yes, not too bad. Good evening. Doesn't feel like an evening though on this glorious sunny afternoon.
I agree. Although I am very tired, so it might the sun's screaming day, my head screaming go to bed. So it's like a weird juxtaposition that I'm not completely managing myself at this moment in time. But yes, it's a lovely day, and it is great to see you again. Just you and me and thee again tonight.
It is indeed. It is indeed. So we're going to have to. Last week we overran by, I think, an hour. We've said that we need to be off within the hour tonight, so we're going to have to keep it short and sweet. We'll fly through the effective domain tonight, providing lots of tips and bits and pieces to everybody. But I watched it back. When was it? Sunday? Was it Sunday evening? Saturday evening? Sunday? One of the evenings. And there were actually so many top tips. And I think where we were flying through the safe domain, I didn't really take it all in. But yeah, there were so many great tips there for embedding into our services, which is obviously what it's all about. But I thought it was fantastic to listen to it back.
Well, honestly, I mean, I know it was us talking, but I've shared that with my managers as well, and I've told them to come and check it out. The guidance on it is just on understanding what the quality statements are alone, I thought was really beneficial. And as always, I learned from you, and I think you learned from me, and it was just a really sort of positive session last week. I think before we get started, we've got two pieces of CQC news, haven't we? We are Ian Trenholm, wherefore art thou, Ian Trenholm? He has stood down, he has resigned. We now have Kate Tironi as acting chief executive of the CQC. They are on the hunt for somebody new. Let's see whether they go for a female or a non-white male with their equality and diversity approach, but that is yet to be seen. There is also a feedback survey consultation out at the moment. Now, if you are registered for the CQC alerts and updates, you will have had this yourselves. But basically, it's how well do you understand our new assessment approach? We would love you millions who said, oh, we never understood it until we watched the Caring View, and now we know it like the back of our hands. That would be great. No, I'm kidding. If you don't have the link to that, I will try and grab the link whilst Mark and I are talking tonight, and I'll pop that into the comments. If you haven't already signed up for the CQC newsletters notifications, I recommend you do. They do send out quite a bit of information through them, usually groveling about the portal not working, but every now and then there is stuff in there that is really beneficial. So do go subscribe to that, and if you can, go and submit your honest opinions around the approach, assessment approach. That will help shape how they move forwards. So, Mark, we're on effective tonight. How many quality statements do we have on effective? 6, I believe, isn't it?
There is indeed 6 statements. So I'll read out what effective means, then we can dive straight into the first one, which is around assessing needs. But the effective domain says that people and communities have the best possible outcomes because their needs are assessed. Their care, support, and treatment reflects the needs and any protected equality characteristics. Services work in harmony with people at the centre of their care Leaders instill a culture of improvement where understanding current outcomes and exploring best practice is part of everyday work. It's quite a overarching, kind of doesn't really tell you what's on the or what's in the tin. A bit like, I think, the safe one, and when you look at caring and well-led, I think it kind of summarizes it quite neatly. Whereas I feel like that one's a bit more wishy-washy than some of the others.
Yeah, I think for me, just the sort of outlining of this one is always, I mean, are we doing as much as we can do for this person? Are we doing it in a way that meets their needs? And is their care tailored to support them? You know, there are plenty of times where I know we've all probably sat there and gone, well, this isn't working, we're going to have to do something else. But actually, do our assessments show everything that we need about this individual? Do we know this person inside and out? Do we know their history, their backgrounds? There's a lot around the effectiveness angle when it comes to how we provide our support. Now, I know there was a comment from last week in the chat, I think post after watching the video, saying it was really, really beneficial. However, they wanted more of a home care spin and a home care angle on that. We will try and do that this week. I am going to put my hands up and admit I haven't been home care for the last 4 years, so things will have moved on slightly since then. But we will try and bring more of that home care angle. Mark, I know you're more in the community, obviously, than I am at present. So we'll be conscious when we do that. But yeah, effective, bit ambiguous from the start, but I suppose we will learn more as we go through the quality statements.
Yes. So I have just shared the link to the CQC website, because I know that last week we had people who were listening, but we're also clicking through the website alongside us. So yes, the first quality statement is assessing needs. So the CQC expect providers to maximise the effectiveness of people's care and treatment by assessing and reviewing their health, care, well-being and communication needs with them. Adam, over to you. What top tips do you have?
So for me, this is the first question that I ask team members, managers, anybody in care, is when we are looking at people's needs, are we assessing them effectively? How often are we assessing them? Are we assessing them alongside that individual? And are we looking at all angles? So, you know, I think around MCAs quite a bit. So when we're trying to involve people in the care and we're thinking, well, actually, we need to do an MCA here, but they've got communication needs that are different to, say, speaking verbally. How are we approaching that? What are we doing? Smoking, for example, this is one that I've had personal experience with in the past. Someone that can smoke, they are pretty much non-verbal. They can only point to certain things. But actually, we were able to use cutouts of different words and phrases and ask them to highlight where those issues were. What would it mean to their health if they carried on smoking? What sort of things would they be looking for, changes in their health, if it's going to affect them in the future? I mean, under this quality statement, they are looking at things like, you know, people are confident that their individual needs have been appropriately assessed and are fully understood. Communication needs are assessed and met to maximise the effectiveness of their care and treatment. You know, obviously we've got the obvious ones at this moment in time, like language. We have got different dialects. We have got communication issues based on cognitive impairment, based on learning disabilities, based on physical disabilities. Using a range of assessment tools to ensure their needs are reflected and understood. Again, there's so many assessment tools out there now that we've got to... Purpose T, for example, Waterloo is still being used in our area. We're moving on to the Purpose T. We're still doing both at the moment, just while everyone gets used to what they mean. I'm thinking pain assessments. Are we using the PAINAD? Are we using the ABI scale? What are the assessment tools that we're using to make sure that we fully get these people's needs? Are we using multifactorial falls assessment? So not they've had a fall recently, etc., but actually we're going deep dive and we're analysing footwear, we're analysing their activity, their medication, their alertness, their continence, all of that. Assessments are up to date and staff understand people's current needs. Flash meetings. Are we having flash meetings in our services? Are we having little internal MDTs, if you will, when we're updating people's records. We've done a care review, but who's done that care review? Is it just one nurse that's done that care review, or actually has the nurse, the manager, a senior carer, a care assistant been involved? Have we then gone to the relative and the person and gone through what the team have said to us and asked them their opinion? Once we've got that updated review of that person's care needs, how are we then communicating that back out to people? Are we just expecting them to read the care plans every single time they come on duty, or actually are we providing that in a handover way? Not a morning handover. They should be nice, short, nice and sort of quick. But what are the other ways in which we're approaching the communication of changes of care needs to people? People's care needs are routinely reviewed. Obviously, we've just discussed part of that. The needs of carers of people using services are also assessed and met. This supports their health and well-being in their carer roles and helps them to provide safe and effective care to the people they support. So this isn't just necessarily, say, our carers, but also the private carers of people as well. Mark, I know you'll probably have more of an angle of this from that home care perspective, but it's important that we have a look at it in that holistic approach. It's the involvement for me, which is the big one on here. How are we evidencing that, and how are we truly involving people? Are we just saying to people, look, I've done your care plans and your care assessments, this is what we think it is that you need? Or are we really truly working with them, placing them at the center of their care, making their decisions? I know we talk about person-centered, but a really good phrase for us to start using and to really embed within our services is person-led. So that person leads the way of their care. They're at the center of everything that we do, but actually they're leading us on their journey of care. They lead us in the direction that they want to go, their health needs that they want to have, their care outcomes, their life outcomes that they want to achieve. So they've got to be able to lead us in that way. So how are we involving them in that assessment? Have we got the right people involved in those assessments? If that person is nonverbal and unable to communicate in certain ways, again, have we used those communication tools to get them involved? Does it mean that actually just because someone has a language barrier with us and they have passing English, so, we can talk to them on a sort of everyday basics. So do you want a cup of tea? Do you want something to eat? And we can get by with that level of English. Is it that when we come to assess their care plans and their reviews, we need to get an interpreter in? So have we thought about bringing these interpreters in? Is there anybody in our team who's fluent in that same language that would be able to translate for them? Do we want to provide that in a written form as well in their native tongue? So we've discussed it verbally if we can't get an interpreter, but we've actually also transcribed it into their native tongue so they've got that additional information that they can go, actually, no, that's not what I meant. I meant this. And we've fully included them in their assessment. So there's a lot of different ways in which we can actually assess how effective our own assessments are before we even try and meet the effective domain here under this quality statement. Mark?
Yes, no, thank you very much. And before I come in with just some notes that I wrote looking, we've got Tina, who's joined us on Facebook tonight. So she has shared needs versus wishes and preferences, expectations, commission challenges also impacts on this. She shared a link in the chat with some good resources for communication, and she's also popped what you said, Adam, person-centric, person-led. There was talk at one point about removing person-centered care and replacing it with person-led from the CQC, but I don't really ever know whatever happened with that. But I do prefer the terminology person-led.
Yeah.
So just some bits from me. A bit like what you said, Adam, it is that involvement. It is that personalization, making sure that you've got the individual's unique needs right in the middle. It talks about the range of assessment tools. So for home care, with my home care hat on, involving the individual, involving their representative, whether that's the husband, the wife, daughter, son, next door neighbor, those that are kind of wrapped around that person, keeping them kind of independent at home, any social workers. There are links on the quality statement, and I'll share it, to the NICE website around dementia assessments. It's also around the person's experiences and making sure that you're capturing actually impact. So it talks around mental health, for learning disabilities, behaviour challenges, lots of communication emphasis, which Tina's obviously shared some links there about. But the CQC website talks around hearing loss in particular. and a lot around transitioning from children's services into adult, but also adult services into adult services. And I think one thing for me around effective, a really easy way of meeting this and evidencing it, is actually sharing the assessment and those risk assessments with the next provider that person's going to, because actually that helps bridge the gap and just means that person hasn't got to tell their story for a second, third, fourth, fifth time. There's links on there. It talks about the National Early Warning Scores, so the news. So many people will have heard of the WASAM blue box, but just the early identification of sepsis. And then just supporting unpaid carers. So we spoke last week about how unpaid carers are a common golden thread throughout this throughout the framework, if I put my teeth back in. But again, with my home care, actually, you'll see so many people that have family members that are unpaid carers. It might be a daughter, it might be somebody older, but actually what you could do is you could refer them to the local authority, make sure actually they've got the signposting that they need, make sure they've got the support they need in place, and follow that up. Actually, if you're supporting that person over a long period of time, actually double check with the wife. Actually, if you heard from the local authority, let's rechase it again so that you've got that support. And also the benefits that come with being an unpaid carer, admittedly nowhere near as much as they definitely should get, but the respite is, priceless when it comes to, obviously, when you're an unpaid carer. So yeah, lots to kind of embed there.
I think obviously around the home care angle as well, you've got that ability to have a look at what their social links they're going to need. Because when we're assessing people's needs and life outcomes, it's not always health related. A lot of it can be social. A lot of it can be how we engage in the community, how are we achieving what we want to achieve socially. And as a home care provider, we're only there for a short period. So are they aware of what's available in that local area? Have we get on them the links for, say, paper routes or anything like that, anything that can support them in those areas. Mark, you're 100% correct around the news too with the early warning score. And I suppose that comes down to identifying people who are prone to infections. Do we have care plans for people who have recurring infections? We had an episode all around diabetes foot care recently. Do we have diabetes foot care plans? Are we assessing for neuropathy? Are we assessing for all of these different little things that could actually potentially cause longer term issues for these individuals? And if we're assessing it early, then we're going to pick up on things a lot earlier as well. So if we know someone's prone to UTIs, we know they're also going to be at higher risk of getting urosepsis. So we know that actually once this person starts displaying these symptoms, not only could it potentially be a UTI, but we also make sure that we're instantly checking regularly for sepsis, using that news to dictate how often we need to be doing those checks. But also, we know ourselves, have we got baselines in their care plans? Do we know what this person's normal cognitive state is? If yes, it's no good up here, we need to get it in the plan. Do we know what this person's normal mobility is? Do we know what their normal diet is? Do we know how they normally communicate? If so, let's put those baselines in that care plan, because it might be that actually their temperature and OBS aren't really showing anything at this minute, but they aren't as coherent as normal. They're a little bit wobblier on their feet. They're a little bit more withdrawn, and they're not eating and drinking. We know then something's definitely wrong because we can see from their baselines something is just off. So it's no longer just relying on that hunch. It's making sure that we've got that documented as well.
No, absolutely. And the only other thing that, just while you were talking there, that I thought about was actually the weather alerts that you can now get. Is actually you can be affected by, getting that. So obviously it's Amber Alert at the moment. Actually, how do you translate that to your staff team, making sure that they're hydrated? Because it's not just about the people that we're supporting, it's also about our staff teams and those that are lone working and making sure that they've got the support and tools in place to do their job effectively as well.
Yeah. I mean, this really just scream communication, doesn't it? It's about making sure that we communicate to people at all angles. It's about providing people the resources to make their own decisions. So I go back to, say, the newspapers or anything like that. We're providing them that information within their local area, or it comes to communicating with their other health partners. So if we've got people who are under tissue viability nurses, under tracheal care nurses, under whatever type of health professional it would be, it's involving them in their assessments and their reviews as well, saying, we're going to be doing a review next month with such and such. Do you want to come down and be involved in it? If not, do you want to join via Teams? Because that's really, really sort of beneficial, or will be beneficial for them. We just had a comment come through saying we do need to be careful that it's our responsibility to monitor all of those, or is the service taking on delegated healthcare tasks? In residential care settings, in nursing care settings, it's down to us. They're under our 24-hour care, I would say. Especially when it comes down to the news too, and identification of urosepsis or any other type of sepsis. I've got urosepsis on the brain today. My granddad went with it recently, and it's just stuck in my head, and I can't get it out. But I mean sepsis. So it is around making sure that we provide that training. Are we doing Restore 2 training? Are we doing sepsis awareness training? Are we doing IPC training? And I don't mean IPC just as in IPC, but actually are we doing some really good infection training as well that covers everything else? So yeah, really, really essential stuff that we need to be thinking about around assessing needs. Let's move on, Mark. Otherwise, I will talk us into 10 o'clock.
So the next one is delivering evidence-based care and treatment. So CQC expect providers to plan and deliver people's care and treatment with them, including what's important and matters to them. We do this in line with legislation and current evidence-based good practice and standards. That's you, Adam. Any thoughts?
Again, I find this part of the CQC framework very similar. And for me, I think to succeed in this, it's easier to refer to the I statements, isn't it? Because we need to be saying to the people that we're supporting, or finding out from the people that we're supporting, I have care and support that is coordinated and everyone works well with me together. Will they answer yes to that? Do they feel like the support they have enables them to live as they want? Do they feel like they're being seen as a unique person with skills, strength, and goals? If no, what aren't we doing? We need to be looking at those I statements. This is one that's probably very personal to individuals. I think hydration needs. It's so easy, especially if you're a person-centered software user in care homes. I don't know whether you use it for home care. It's very easy to get stuck into the habit of putting somebody on a fluid watch and that fluid watch instantly being set to 1,500 mils. But that person who weighs different to the person next door to them needs a different amount of fluids a day. And actually, are we making sure that we're involving them and assessing? Well, I suppose this goes back to assessing needs, though. Are we assessing it effectively? Are we using gig calculators to be able to do that? Are we finding out from the person when it comes to fluid intake, and this is probably part of this quality statement, what sort of fluids they like? Because actually, if they're at risk of dehydration and they're not really drinking the water or the juices that we have available in the home, and they go, actually, I prefer Vimto. I know it's just blackcurrant, but Vimto is my favorite. Are we buying that in? Are we looking at those individual things to that person that helps us meet their needs? But when we're talking about it in line with current guidance, are we making sure that ITSI frameworks are being met, that we've consulted with the SALT team as part of the assessing needs, but when we're delivering that care to these people, we're doing it in a way that meets their calorific intake? So are we having a look at the food we provide? Are we managing that effectively for those individuals? And have we got that ability to see what the average calorific intake would be for someone? Systems ensure that staff are up to date with national legislation, evidence-based good practice, and required standards. One quick fire way to make sure that you can do this: bang up some job descriptions or terms of reference or roles and responsibilities for some champions. And I know champions is a bit of a twee statement, but get yourself some IPC champions, get yourself some nutrition champions, hydration champions, safeguarding champions, whatever you want to champion within your home, and then provide them each week with 1, 2, 3 hours of time whilst they're working to go away and brush up on their knowledge, find out what is new, what is going on, what are the current trends within the local area, and then I'll rely on them to feed that back at team sessions, at huddles, at meetings. Utilize your team to go out there and learn this information, because we're empowering them, and we're asking them to take on more responsibility. But actually, it's peer support, it's peer supervision, it's group supervision, and we're sharing all of that new information that they're taking and putting that into the team to hopefully increase our offering and increase our ability to provide that effective care. What do you think, Mark?
Yes, so all good stuff. I think for me, with this quality statement, you really need to dive into the best practice guidance, because I feel like you said, it's very similar to the first one we've discussed around assessing needs. And it doesn't on the surface appear that there's too much difference, but actually when you start diving into the subtopics and then the best practice, actually you do get the flavor of where they're going. So you spoke there around nutrition and hydration. So many best practice links there around into things around nutrition and hydration. I know I say this all the time. The only thing I would say to everybody, if you haven't watched or if you've heard this 101 times, I do apologise, is that the best practice, the CQC do say that they expect providers to be aware and follow best practice guidance. So it's not a nice to have, it's not an extra, it's part of the framework.
I mean, under their best practice guidance for this one, they've got the must tool. And I'm like, but that's surely that is just like a standard now in everything that we're doing. So yeah, you're right, Mark. This is stuff that we should be doing anyway. The best practice guidance for this one is a little lengthy, but actually full of really good stuff.
We've also got around good governance. So I was looking through some inspection reports with services that have kind of not scored highly in effective generic policies. I think there was always, even before this framework, inspectors that liked the generic policies and those that didn't like generic policies, but actually they're being picked up in inspection reports now. So if you are using a system that is generating all your policies, make sure that you're going in and editing them to make sure that they're fit for purpose for your service. My personal advice would be to create them yourself or use somebody that can bespoke them to your organization, and they don't cost the earth. You don't need 1,000,001 policies. Actually, you just need the ones that are relevant to your organization. Checking with your insurance company, because quite often they'll tell you the key ones to got. So even if you've got those key ones that cover you really well, lack of audits are on there, or lack of action taken, lessons learned, a bit like what you were saying, Adam, taking it back. And a number of them that mention around involving people, but not involving them in terms of like staff teams having conversations. So the quality statement and the best practice talks about medical and clinical committees. So I suppose putting my home care hat on, one thing that we do in my organisation is customer meetings, which you could easily do. So not a team meeting, they're purely just to discuss the people that you're supporting, what's going well, what's not going well, are there any support needs that haven't been identified? Do you need any additional support? Does the person need any additional support? Taking it back to that unpaid carer that obviously we've spoken about, actually, is the unpaid carer okay? Do they need a break? Do they need any support? Can we signpost them to anything else in the community to keep them safe at home? Tina has just mentioned there around news training, just to make sure that it is in the contracts if you're signing contracts with local authorities. The only thing I would say is in Essex is that they were rolled out to all the care homes funded, and now the funding's been stopped. There are a number of providers saying, well, actually, we now can't afford to keep this going. So I guess that goes back to that collaboration between health and social care of actually you need to make sure that communication is hot to make sure there's no kind of gaps in that those healthcare needs. And she agrees on policies, just to read policy for company. Totally agree on policies. Just read a policy for a company tonight, totally contradictory. And that's where you'll fall foul with the CQC, is if it's saying that you do one thing and you're doing completely different. And it might be your recruitment one, which gets pulled up quite a lot in the inspection reports, where it might talk about actually that you're going to get 3 references, and actually in reality you only get 2. So yeah, do make sure that you read that. Before we dive into the next one, Adam, although I can see you were going to come in. Do you want to come in? I was just going to talk about some of the other areas that providers might fall short. So best practice guidance, we've obviously spoken about. Lack of communication, so from leaders downwards, so it might be from your CEOs, from your directors down to management. Lack of multidisciplinary approach, so that lack of joined up working with healthcare professionals, with district nurses, with physiotherapists. Information is not accessible, which you spoke about earlier, Adam. Lack of medication reviews, a lot of references to stomp and stamps, so removing the over-medication of people. Lack of coordination when people require support from 2 care workers. A number of these were home care providers, so actually if you're going to make sure that somebody needs 2 carers, either put them, if they want the visit early in the morning, first thing on the round, so actually both carers are going to turn up, or make sure that visit is non-movable. So actually they've got to be there at a specific time for that person so that both staff turn up at the same time. Poor access to healthcare provision, so to GPs, to dentists are listed a number of times, especially if you've got somebody bedbound, somebody in their own home, even in a care home. Actually, getting a community dentist is an absolute nightmare, but you need to be doing all you can to access those healthcare for people. Lack of consent is on there, which surprised me. Lack of advocacy and support. So again, if you're looking after people that don't have families, don't have representatives, that don't want to be involved in their care, or there's a family breakdown or whatever, actually, have they got an advocate and somebody that can kind of fight for their behalf? And obviously, we spoke about this earlier, but poor transition between services is another big one. So yeah, just some bits there that we can do to prevent that from happening in the future. We're ready to dive into the next one, Adam?
Yeah, I was just going to say, on your marks, on your comments around the news and the training, get yourself on the Restore to trainers, because then you can train your own team, save yourself loads of money. You know, I would always say when it's stuff like that, get a trainer course, train some people up, and then start training people, because it's just a lot easier than trying to keep finding those courses and keeping on top of it.
I will also quickly share these in a minute. The best practice guidance also links to the Getting It Right First Time, which came out in 2020 originally, was updated in 2022.
Good old
oh, what's that? Sorry?
Good old gift.
That's it. That it is. And the other one that it links to is an inspection toolkit from Skills for Care. So you can begin to toggle around with whether you're a residential or home care, an LD service, supported living service, and you can click through. And it's actually a really good toolkit to have. So I'll share them in the comments in a minute. So the next quality statement is how staff, teams, and services work together. So CQC expect providers to work effectively across teams and services to support people. We make sure that they only need to tell their story once by sharing their assessment of needs when they move between different services. Adam, over to you.
Again, I feel like this is all very straightforward, this sort of stuff, because if someone's going to hospital, and I can hear you all screaming from this side, but the hospital lose their documents, and I get that, I totally do, but what are we doing as providers to make sure that actually that continuity of care is being sent over? Are we sending baselines of these individuals? Are we saying to them what they are, their usual abilities are when it comes to mobility, speech, cognition, nutrition, etc.? Have the team got access to this information? So how are the team accessing the care plans? How are the team accessing those risk assessments or those updates and those information? And is the information that the team are accessing relevant to them? Because if we're going to be doing care plans for individuals, we need to make sure that actually the care team know where to look and the nursing teams know where to look, so that they're not having to sift through all that information. They can find that information easy. They've got it to hand. It's nice and in their right language for them. When I say right language, I don't mean abbreviations and technical jargon. It's easy to understand. So actually they can go and provide that safe care and treatment to those individuals based on what their care plans are saying. We've got people who may move between our own service. So if we've got a home care service and a residential home, and then moving between those services, what information are we providing to individuals? When it comes to consent, are we getting that consent to share whole care plans and risk assessments for individuals? So when they're going to different services, we can send that all over, like Mark had mentioned earlier. We might have people moving within our actual home. And we might have part of our home suited for residential, part of our home suited for nursing. How are we assured that the information we then send over to that other side of the home is going to be informative, so that they can continue to provide that care in an effective way for them? When we are talking around sharing that information, we also have to think around, and I suppose I've already touched on this already, the different types of care team that we have involved. And I probably also want to bring the kitchen team into this as well, because if we've got dietary nutritional needs, how are we making sure that the kitchen are aware of the needs of these individuals without sharing information with them that they don't need to know? Because they don't need to know the entire care plan. What they need to know, though, is what these nutritional needs are for individual, and how are we including them in that process for these individuals. And it's talking around the swallowing and the makeup of the diet and etc. Are we actually involving the people who deliver that care to them? So the care team who will be supporting with nutrition and hydration, and the kitchen team who are there preparing the meals, they're important, and they need to be involved in the relevant care planning side of things for these individuals, where they're going to have quite a lot of the control or influence into their care. I don't know what else to say, Mark. I suppose I struggle with this because I find it very self-explanatory, and I think for me, our care plan should have everything in that we need to be able to provide this effective care, and sharing it with the teams and external services. Have we got hospital passports? Put a hospital passport together. Does it include a catheter passport? Does it include an antibiotics passport? So do they know what size catheters this person uses? Do we know what antibiotics work for them, what antibiotics don't work for them? And have we got dementia passports, cognition passports? Do we have Herbert protocols in place? Are we sharing conditions of dolls with individuals so they know what conditions they have while they're living with us? For me, it's a lot of that.
Yeah, no, I would completely agree. It does feel like they've just added this quality statement in to bulk out the effective domain. Some of the things that, even when you go through the best practice, half the best practice guidance is just already been in the other two that we've discussed. So some of the things that I've taken from it is your staffing levels. It does refer to that. So actually, one thing I would make sure, we know that feedback is critical in this new framework, is how have you determined how many staff you have on shift, or have you determined how many staff that customer that you're sorting in their own home needs? I would make sure that's evidenced per individual. If you're using a toolkit, then make sure you're keeping copies when you filled in that audit to determine that. We know that CQC will ask staff, do you have enough staff on shift? Do you feel like you've got enough support? So that is a question they'll ask. They do ask family whether they feel there's enough staff on shift, and they will ask the people in the service whether actually people are, and this falls under the responsive as well, but are people responsive to your needs? So you do need to make sure that you're evidencing that. We spoke about this last week, but continuity of care. So making sure that if you're a home care provider, limiting the number of different carers that are going to that individual. And interestingly, and I do feel like the CQC have missed something here, one of the subtopics is sharing information. But there's nothing there around GDPR, which does surprise me, and nothing around DPIA, so data protection impact assessments and bits and pieces. And I'm surprised it doesn't link back to the words got out my tongue, but the toolkit that we all complete to get the NHS email. You're correct, Adam. Yes. Which I'm surprised it doesn't all link back to that, actually, if we're talking about information sharing. And it still talks around transitions and bits and pieces. So actually, yeah, does surprise me. But
I think when it comes to information sharing, I think some of the things I would mention is, do your relatives and do your residents know how to request the information to be shared with them? And do they understand how to request for it to be shared to other people? Are we providing that in that easy read format? Again, that comes under assessing needs and the previous two quality statements under this domain. But for me, it's around, do they understand the process, and do your teams understand the process of how to share that information? Because actually, you can't just go, yeah, here's a picture, I'm going to send it off. Here's the care plan, I'm going to pop it in the post to you. We need to make sure that actually the people we're sharing the information with have gone through the correct routes to be able to access that. Paul has put in the comments around making sure that you've got a printout if necessary. Totally agree. Problems we've got with printouts nowadays, and this again is something you can solve internally, how you're going to manage this, is care changes on a daily basis. So if we print something out on a Monday, by Friday it's out of date, and do we really want to print it out every day? Or is there a way that we can delegate or make sure that, because I know what you're saying, especially if admin office is closed, but is there the ability for us to be able to print these documents off in non-admin offices? is that an accessibility thing we need to think about nowadays, where we need to have 24 access to printouts of these documents? Is there anything that we can do? Making sure we read discharge letters when people come back to us, ensuring medication changes and future appointments are noted 100%. Making sure we safeguard hospitals when they don't send us the discharge letters as failed discharges, because unsafe admission, how are we to continue the care if we've not been given the notification or the information from the hospitals? Got to remember, single assessment framework. So this quality statement that we're discussing now, your hospitals will also be assessed under this quality statement. And if they're getting safeguardings coming through because they are not supporting the safe transition of people, then what's going on? You know, make sure that you're providing that information out there.
The only other thing that just popped into my head around sharing of information is around AI. And would it be great if there was an AI guide for social care, which I will share a link because we do have one on the Care Review website. But actually, around if you're sharing information into a software that you're using that is powered by AI, actually, how do you know that people understand that you've got their consent? A lot of the digital care planning is starting to use AI. A lot of the communication tools that are out there use AI. Zoom, Teams use AI. A lot of teams use WhatsApp. It's powered by AI. A lot of us have Facebook groups, Facebook pages, all powered by AI. So make sure that actually you've got some privacy notices, you've got consent from staff to start using their data on all these tools. But I'll share the link to that guide in the comments. Next one, Adam. So the next one is supporting people to live healthier lives. So we support people to manage their health and well-being so they can maximize their independence, choice and control. We support them to live healthier lives and, where possible, reduce the future needs for care and support. What are your thoughts?
So again, I like the effective domain because for me it is really self-explanatory and should be one of the easiest ones in which we can get goods and outstandings in. So for me on this one, very simple things. What is it that we're health conscious about? And I would start like that. So I'm conscious about my weight. I'm conscious about how much I drink. I'm conscious that I smoke. I'm conscious that I don't exercise enough. I'm conscious that my gums bleed when I brush them. I'm conscious that I don't necessarily see the best sometimes, even when I'm wearing my glasses. So if I'm conscious about all of those things, surely my residents are probably conscious about this as well. And how do I support them in this? So are we providing stop smoking guidance? Are we explaining the benefits and the sort of health benefits, long-term benefits of not smoking? Are we providing guidance on vapes and the different types of vapes that are out there, as safe disposal of them, safe use of them? Are we finding out from them actually whether they want or whether they've got any concerns around their health? When it comes to exercise, are we providing them support around local gym memberships, local availabilities, the best sort of exercises to meet their needs? We've done falls risk assessments for them. It might be that running and walking is not an exercise for them, but is there seat-based exercises that we can promote for people? When it comes to diet, are we explaining things around the BMI? Are we explaining things around those sort of high risk factors, cholesterol levels, impact on our heart, impact on our livers? Are we talking about fatty livers? Are we talking about how much we drink? And when I say drink, I don't just mean alcohol. We might have people who are absolutely addicted to that god awful Prime stuff and all those other energy drinks that are out there full of salts and God knows what. Have we got people who drink too much caffeine? Have we got people that drink too much coffee? Coffee makes your bones brittle. Are people aware of these risks? If they've got osteoarthritis, are we telling them about the impact that coffee can have on the bone depending on how much they are drinking? So for me, it's finding out all of those different factors around those people's health concerns, and then working with them on it. It might be that they suffer from insomnia, they suffer from anxiety, they suffer from seasonal affective disorder. There might be a multitude of things that these people are living with that we're not aware about. And if we don't, and I go back to assess their needs and understand this, how can we support them to live those healthier lives? So it's really around, and I would say, all for one for all. There is nothing worse than being told by somebody who doesn't look after themselves that you need to look after yourself. And I know that's a very difficult thing to hear, But if you're going to be supporting your team, your residents around making healthier choices, healthier lifestyle choices, make it an organizational wide thing. Are we providing our team with all of these different benefits? Are we providing guidance in areas around gambling addictions and other forms of addictions? Are we providing safe sex guidance for individuals? And when I say safe sex, I mean, yes, prophylactics in condoms and stuff like that, but actually the sexually transmitted disease side of things. Are we explaining the differences and the concerns around that? Are we supporting people around oral care? Are we telling people about flossing, interdental brushing, the differences between manual and electric brushing, mouth washing but not for long term? Do they have a dentist? Do they want a dentist? What are the sort of dental concerns they've got? So a lot of this is for me, again, very self-explanatory, but is very quick for us to have those quick wins on. And again, if we can demonstrate this with sort of outstanding practices, a really good one to get outstanding on or to work towards outstanding in the effective domain.
No, absolutely.
Oh,
the only
sorry, for people who are able, who have technology, are we encouraging the use of Fitbits, Apple Watches? Are we encouraging health tracking? You know, we've got so many people now who are moving into homes with all this technology. Actually, are we showing them how they can track their pulse and track their health and look at those signs and symptoms themselves to be able to go, oh God, my pulse has shown up as this. Is this okay? You know, I've got this concern because this has come up, and I'm assessing, you know, my health in this way. I only managed to get 4 hours sleep for the last 7 nights in a row. I think there might be something up. Can we investigate it? You know, it's all around that for me and getting them to have a bit more of that control. A lot easier for people who have the capacity and the ability to do so. But for those who don't say have that capacity and ability, it's still around making sure we're informing them as best we can so that they can make those fully informed decisions. A difference between educating and forcing our decision on people. What we shouldn't be saying is you should stop smoking. What we could be saying is, do you know what the benefits of smoking are? And do you know what the potential effects of smoking are? This is what they are. This is the information. It's for you to make that decision, but we will help you so we will support you in that decision you make, as long as we can provide you all of the information to make those healthy life choices as well.
No, absolutely. And I think you do need to make sure that you evidence actually if people have capacity to make those unwise decisions, but also that you are still encouraging it. So you're still having those conversations. So actually they haven't said, no, actually, I want to smoke 50 a day. And then you've just left it in their care plan. Oh, I spoke to them in 2009. They want to smoke 50. Actually, you are reviewing that and you're still offering that support. And things change. The support networks that are out there change. The technology, the healthcare changes. So making sure that you're refreshing that. One big thing, I put my LD hat on here because it's definitely common in LD, is around nutrition and people having capacity to eat fast food, especially McDonald's, which seems to be a massive thing in LD services. Actually, yes, they might have capacity to choose they want a McDonald's, but do they have capacity long-term to understand the long-term implications on their health, which a lot of providers don't do that long-term planning and quite often then fall foul of more so PAMS inspections, so local authority inspections, and the CQC, but definitely something to think about. It talks around preventing loneliness in there, and a link to NICE around identifying risks a lot earlier on. So what you spoke there about, Adam, earlier about stopping smoking or people adopting a healthy diet or being physically active, there's a whole guidance that NICE have put together around how you can identify that early on. So I will share that in the comments.
And just on the loneliness, our friends over at Adopt a Grandparent, go and check out that initiative. Great way of looking at combating loneliness. But actually, what programs have we got internally around combating loneliness? Do we understand what makes people feel lonely? Because we could be in a room full of people and still feel lonely. So actually, what is it that's important to individuals when it comes to that side of things? I suppose if we look at the I statements on this, we're going to be expecting people to say that they can get information about their health, their care, their support. They've got, they have care and support that is coordinated and everyone works well together. I have care and support that enables me to live as I want to, seeing me as a unique person with skills, strengths, and goals. So as Mark said, making sure that we're recording all of those conversations and we've got that evidence to make those individual decisions that they want to do that we may see as unwise choices, but are actually those individual choices to that individual. And that we're supporting them to do that And again, as long as we're providing that information, I suppose all of this happens all in one go. So when we do that assessing the needs and putting all those care plans together, all of this falls in at the same time, because actually, let's say somebody is on carbocisteine, they can't shift the phlegm on the chest, and actually it's getting worse, the medication can't go any higher, the doctors are saying there's nothing more we can do. Those are the conversations we need to be having to them by saying, but you smoke, and do you actually understand how this might be impacting your chest? And should we have a look at ways in which we can either reduce how much you smoke or move on to something that still provides you that nicotine buzz that you need, but actually does less damage to your body and your lungs? Although we're at a point now where we're not going to improve greatly, what we can do is try and stop it from getting any worse. And providing them with that information, because as long as you've documented and you've recorded that you've tried all of those angles, and actually they say, no, I prefer my Richmond, and that's what I'm going to do. I'm going to continue smoking. But we've evidenced it. We've had those conversations. We've done that best interest. We've done that mental capacity assessment, and we've done those MDTs, and we've supported that person as much as we can do to make those decisions that matter to them. They've chosen what they want to do, but we've got that evidence there that supports us as well. But again, for me, very straightforward, this one. This might be me sounding really arrogant. If people are struggling with this domain of the framework, do get in touch with us, and we can provide some more bespoke information. We'll have a look at what documents we've got on the website as well, which might support these quality statements.
No, definitely. And I know you just mentioned there, Adam, around adopted grandparent. Just wanted to, we did a podcast, it's not out yet with them, but actually such a great initiative that, it doesn't have to be people signing up to talk with a grandchild. It could be them connecting with other people, so they could become a volunteer themselves. But yeah, some great success stories there around preventing isolation, networking people across the world. We heard one amazing story of somebody that was non-verbal. Actually, they connected somebody back with the same historic roots as him, and actually how he's now started talking and engaging with his volunteer, but also the care home staff. So yeah, some great stories. I've shared the link to them. Everything's free. They provide all the risk assessments and bits and pieces. So actually they guide you through the whole process to make sure that you're compliant. And also the CQC absolutely love them, and it talks about that on their website. So next quality statement is monitoring and improving outcomes. So we routinely monitor people's care and treatment to continuously improve it. We ensure that outcomes are positive and consistent, and that they meet both clinical expectations and the expectations of people themselves. Back to you, Adam.
So I'm not going to lie, I actually love this quality statement. It's nice and short, but that's not why I love it. There's not much that we're expecting in this, but actually, this is probably one of the biggest changes you can make in your organization, especially in your care planning side of things. How many of us have sat and read care plans and the review's gone, care plan reviewed, no changes needed, or care plan reviewed, care to be continued as required? And actually what we're reading is a nutrition care plan, and the outcome is to have 3 healthy meals a day. And we're going, great. How do we measure that? How do we monitor the impact of these life outcomes? How do we monitor the benefits of the nutritional care this person's receiving? Would it not be better for us in our outcomes to have this person's ideal weight is this, they want to maintain their weight at this, so the outcome of their care plan is to maintain a weight of plus or minus 0.5 kilograms of this weight. So that actually, when we go to review the care plan, what we need to be doing is going, I reviewed the recent weights for this individual. I can see that on average, over the last 4 weeks, their weight has been this. That means they are 2 kilograms under the weight that they think is desirable. Therefore, we need to have a look at their nutritional care plan and their nutritional support to ensure that we can get them back to that weight that they desire to be. That's what we should be reviewing. We should have these reviewable measurables in care plans, and very, very rarely do we. Sleeping care plans to make sure they have a rested night's sleep. What's a rested night's sleep? For me, rested night is I can go to bed at midnight, get up at 6. For my partner, 10 o'clock in the night, 10 o'clock in the morning, they will do a full 12 hours. That's a rested night's sleep for them. When it comes to sleep and the outcomes of positive sleep, how are we measuring that? So yes, we could say actually they've slept all the way through, great, but are they rested? So we've said rested night's sleep, and rested is a very important term, because we could say uninterrupted night's sleep, which means they're uninterrupted. but they may not be having a restful sleep. So how are we checking for that restfulness? Are they, what's their mood like? Is it within their normal sort of baselines, or is it erratic? Are they irritable? Are they eating as much? Are they drowsy? Are they falling more? And those are the things we need to be monitoring and measuring when we're going to review sleeping care plans. So there's a lot for me around this, around when we're doing our care plans. Have a look at your goals. And if you say to yourself, I can't measure that, or there's no way that I can assess the impact or the outcome of this care plan, then you need to change the goal and the outcome of it to something that is more measurable. You need to be able to identify what it is within that person's care notes. Because when we're reviewing a care plan, we're not just sat looking at that care plan going, this care plan's correct and nothing needs to change. What we need to do is I'm going to go through all their care notes. I'm going to have a look at their charts. I'm going to have a look at what their health's been like recently. I'm going to look at what the behaviors have been like, how much they've eaten, how much they've drunk, how many times they've fallen, how many accidents they've had, all of that sort of stuff, because then we use that information to review the care plans. However, if in the care plan we do not have those areas that we can identify to review and to monitor or to check for progression towards the outcome of that person's goal, how are we reviewing those care plans? Are we just putting care plan reviewed, or are we looking at it and going, this is a measurable outcome, I am able to measure this outcome, and this is my review. Nothing needs to change because actually this person's weight has remained the same. They've eaten every single day. They've never really missed a meal, and their weight is at the level that it needs to be. So when I come and read those care plans and go, have you reviewed this care plan? I can go, they have. Why have they reviewed it as no changes needed? Well, they've reviewed it as no changes needed because there's a measurable outcome. The weight's not changed. They've had all their meals. They've checked the charts. Everything hunky-dory. There's been no choking incidents, yada, yada, yada. Great. I now understand why no care needs to change in that care plan. If I see a care plan and it just says care plan reviewed, no changes needed, I'm going, why? How have you come to that conclusion? How have you assumed that? Have you assumed that? Or actually, have you got the empirical data to back it up? And actually, there's no outcome or goal in there that you can measure. How, 3 healthy meals a day. Are you going through every single meal that this person's having and monitoring the nutritional value of each meal? Probably not. Totally unmeasurable outcome. Making sure that those 3 meals a day support that person's nutrition needs to keep them at a weight of such and such, and also, meets their diabetic dietary requirements or is in line with their ITSE framework. Great, we can monitor that. But we cannot be putting things that we just literally physically cannot measure and monitor and actually show no impact to that person's life. It could be that the outcome, and I'm going to stick on nutrition, is to reduce this person's MUT score or to reduce the overall Waterloo score. All of that is measurable stuff, and that is what we need to be looking at for me in this section, because it allows us to provide that continuous improvement to that person's care. Again, use your clinical tools that are out there. Use your Waterloo, use your Purpose T, use some hydration giga calculators that are out there. Use your pain nav tools. Use whatever sort of tools it is for whatever area of care we're providing to people. Just make sure that we're evidencing it and that we're actually using and monitoring the impact of it, and that those goals and outcomes are measurable.
100%. And if there's anybody that wants to know more about that, I actually have a blog coming out tomorrow just on that one area. So be sure to, it'll be on my LinkedIn and my Twitter. So yeah, that'll be out tomorrow morning. But it surprises me here that there's no best practice around linking that to the benchmarking, or even naming it like service improvement, or something that everyday folk can get their head around. But it does surprise me they've just kind of left it very open-ended. All the notes I wrote, Adam, were around that benchmarking, which you've just explained perfectly. So nothing else from me. Anything else from you before we dive on to the next one?
No, but I am tempted to put together a document. I've already started it for my own services, actually. So it might be that I share it with the Caring View, the goodness of my heart, with examples of outcomes for different types of care plans, so that actually we can get into our heads, not to copy and lift them because everyone should be individual, but it gives us an idea of what we would be expecting to see as an outcome for a care plan, if that makes sense, rather than just, to maintain good skin integrity on their feet. For example, actually what we need to be doing is X, Y, and Z, and that's the outcome we need to be monitoring, etc. So I'm looking at doing that. Just one second, my cats are fighting.
No, that's okay. No, that sounds really good. And also, if there's anybody thinking, I don't have a service improvement plan or nothing to benchmark, you need a template. On Friday, there will be a template that I'm releasing as well, so you can download that for free. The only thing that quality statement does also talk about is around accreditation schemes and how they take them into account. I'll share the link. It talks about independent healthcare providers, but it's also under the regulated services as well. So I'll share that and then you can just map it back in, but there doesn't seem to be anything for adult social care per se. So the next one is the last one, consent to care and treatment. So CQC expect providers to tell people about their rights around consent and respect these when we deliver person-centred care and treatment. I don't know about for you, Adam. This one just seems the most obvious one that should be a given, but let's dive into it. Over to you.
So for me, when we're thinking of consent of care and treatment, where is it documented in the care plan that we've got the consent for that individual? We can never just run off that consent. So it's really good practice for us to get our team into the habit of saying, are you okay with me providing you support? Are you okay with me helping you have a wash? Are you okay with me doing this? Because actually that allows us to measure on a daily basis that we're looking at that consent for individuals. It might be that we've got individuals whose care plan states that no matter what circumstance, they're going to be really resistant to care. That's when we have our PBS, our dolls and all of that in place, and our nappy training, etc., etc. But for a lot of people, it's just general, common courtesy. Do you mind if I support you to have a bath? Do you want me to give you a wash in your arms, or do you want to do it yourself? Do you want to try and put the clothes on yourself, or would you like me to support you with them? What sort of clothes would you like to wear today? What colours are you feeling today? All of that is really important and really good for your care team to start documenting, because if they do their care notes with, I assisted Joe Bloggs to have a wash this morning, he gave consent for me to do this, or assisted with consent and supported Joe to have a wash, or assisted with consent and supported Joe to brush his teeth with his favorite toothpaste, which is strawberry. It's bringing that person-centered approach, that person-led approach to the care notes that we're evidencing, so that when I look at the notes, I can go, oh, do you know what? This person's really been supported in a way that's meaningful to them. And actually, we've gained consent on the day. I can see we've got consent in the care plan. I can see we've done mental capacity assessments. We've got best interest decisions. I can see that the consent is for individual aspects, not necessarily a blanket consent approach where it's not necessarily suitable. But I can see from the care notes that actually the team understand what consent means, and the team understands how to ask people what's important to them and what matters to them. I'd be looking at things like gender preferences. I'd be looking at things like religious preferences. How are we making sure that people have the right to choose or are involved in the decision of the care that they're receiving from the people they're receiving? And if it's not always possible to meet their needs, how are we gaining consent to go outside of those boundaries that people would like? Some religions, females can only be supported by female carers. So how are we documenting that, and how are we making sure that that's being done in the way that is meaningful to them? Mental capacity assessments, again, making sure that they've got the ability to make that consent or to give that consent, and if they don't, we've documented it. We've documented how we've reached that decision. We've had best interest decisions, that's care plans, and we've involved people that are meaningful to them or are involved in their care on a day-to-day basis. It's really, really, for me, Mark, really self-explanatory, but really, really hard to get right in a lot of cases. I think a lot of people nowadays put these care plans together and off they go, and actually don't give a second thought around that consent angle. Locked door policies. Have we got consent for people to close their doors at night? And if not, why are we closing their doors at night? If people have capacity, have we got consent from them to interrupt them throughout the night to make sure that they're okay? And if not, why are we doing it? That's going to affect their overall health needs and won't provide us with that effective life or care outcome that we're expecting for people. So for me, it's just around making sure that we've got everything to hand to support them. DNA CPRs, PPEs, PPDs, advanced care decisions, hospital passports, Herbert protocols, PEEPs. For me, all of this stuff we need to be looking at under this consent side of things, so that they are fully informed of the decisions they're making. We're fully aware of what it is they're making a decision on. We've got the mental capacity assessments to back it up. We've got the documentation there. And we've consulted with potentially RPRs, advocates, relatives, loved ones, LPAs, or anyone else that is meaningful to them. Yeah, very straightforward, Mark, but unless we document it, very hard to prove we've done it.
No, absolutely. I think the only things for me is it talks around clear information if somebody's got proposed care or treatment. So actually, have you documented and spoken to people about the risks, the complications, are the alternatives? Actually, the staff removing their own thoughts and opinions. Actually, if somebody does not want treatment, their right to refuse and how you've documented that. Putting my LD hat on again, but also for older people, there's a lot of people that are scared of the dentist. Actually, how have you alleviated some of those concerns? Have you spoken to the dentist? Can they be the first one in the day to get it over and done with the person rather go in last thing in the afternoon? So actually, you've got their choice. Adam, you spoke there around advocacy. It does talk about that again in this quality statement. Talks about non-resuscitation. It also has a couple of links in the best practice around CCTV, which is something we haven't spoken around, but with consent. Actually, have you got the consent of the people that you're supporting to be on CCTV? Now, we have had Jane Connery from Care Campaign for the Vulnerable join us a number of times on the show. Jane does a load of work around CCTV with small providers, larger providers, supporting you kind of if there's concerns that staff have got about being recorded, might be that there's family members that want it in bedrooms and bits and pieces. So I will share her link into the comments. So if you have got questions or you're thinking about implementing it, do reach out to Jane, who I'm sure she'll support. Anything else, Adam?
Social media, huge. Pictures, huge. When it comes to social media consent, are we looking at, can they consent to have their photos taken? Yes. Do we understand? So first things first, we've got a nice, lovely care profile and a marshy, and we've got a big picture of someone's mush on that front page. Great. Do we have consent to use that photo and take a photo to do that? I know it's important that we have that, but it's super important that we get that consent for that photo. And if we do have consent for that photo, is that consent just for photos to do with their care plans, or is that for photos that can go into social media and to other marketing materials? And if it's for other media and other marketing materials, have we got any sort of documented conversations and MCAs around how impactful social media can be? Do they understand that the internet's forever, that we can't control where those pictures go? Do they understand how far that imagery can go and how wide that can go? So think around consent for a lot of things. We use a lot of digital systems now. Are we consenting for data usage? So it's not just about putting our data into a care plan. It might be that we have them on a CRM system and a CRM program. Have we told them about that? It's all that information that we're using for them and making sure that we've got that consent. So just be very clear with yourself what it is that you need consent for from these people, and then make sure that you seek it. And if you do not gain that consent, you do not do the things that they've not consented to. So if someone doesn't want a picture being taken, you do not take a picture. You care plan it to say that they don't want their pictures being taken, and you provide descriptions of who that individual is, for example. It's one of those where it can become quite problematic. And that's why we need to be very clear around the usages of, say, that information. Mark, you're right, around the CCTV, around acoustic monitoring, all quite important.
No, absolutely.
Are you getting married?
That is the church bells in the village, and they are very loud tonight. Very, very loud. But no, I'm not getting married. I have been married for 14 years. So yeah, sadly, not my anniversary today. But yeah, every Tuesday evening. And normally you can't. I always think I was always really conscious of it. And then I remember I used to message and like, can you hear the church bells? They're very loud. But yeah, for some reason the wind must be flowing. There's a row of houses behind us, and then the church is there, so it's just just down the road. Oh, they've stopped now. They must have heard us. Maybe somebody's watching at the church and they thought, oh, guys, stop. They can hear. But before we let everybody go, just wanted to talk about a resource that we have recently shared onto the CQC website around the quality statements. So we have released some free quality statement posters that break down each of the key questions. Adam has shared them on the screen there. Adam, don't know if you want to talk through them more, because this is your handiwork. And whilst you do that, I'll share the link into the comments.
No, not really. I just think, do you remember when we used to have the Chloes, and there used to be that really famous Chloe poster designed by one of our friends that used to go around, and everyone used to download it or print it or order them and what have you. And I thought to myself, I've not seen anything for the quality statements yet. There's probably stuff out there, but actually, won't harm us putting something together. I use these in my services. I truly believe that the framework is great and it's working wonderful, but I really struggle to find people who aren't involved in the day-to-day usage of quality monitoring or assessing alongside the framework. I'm struggling to find people who do know the ins and outs of it. And I do believe that CQC, when they start coming around and asking our teams now, will be asking things under these quality statements. And I think it's really important to us that our team get to know these quality statements inside and out. So I've got these in my team break rooms. I've got them in clinical rooms. I've got them in managers' offices. They have the related regulations to them included on them as well. It's one of those things that the regulations are our Bible. We should know this now, and actually our team should know this. So I've started to plant the seeds with this, and it's going to be turning more into a monthly potential CQC training session for all of my team, so that they understand what the framework is, they understand how those assessments are going to take place, what to expect when a CQC inspector comes, and actually what we mean by these quality statements relating to our business. It might be different for each community, it might be different for each home, it might be different for each service. So I just thought they were a really quick, surefire way of getting these quality statements into the mindset of the people that we support. Use them, don't use them. They're there just to provide that additional information, and they're completely free. It just costs you whatever it's going to cost you to print them off, which is cheaper than buying them online, I presume. Just make sure if you are printing posters off and they're going to be up in areas, you laminate them, wipe clean, IPC and all that jazz.
Yeah, no, I really like them. I think they're really informative, and I love the fact that it's got the related regulations next to it, because I think actually we get contacted by a number of people that are thinking of becoming a registered manager, new into social care altogether, and actually worry about that fit for person interview and around the regulations, and they don't know them. And actually at that point in your career, the CQC don't expect you to know them all off by heart, but they expect you to know where to find them. And actually this tool, you would be able to link back to that interview process and say, well, actually, I don't know all the regulations, but actually I do have these 5 posters. It talks around all the quality statements, and underneath each one, it links it back to the regulations. So actually I would know that if I was looking at assessing needs, actually I need to go back to regulation 9 and 12. And you could show these to the CQC, because they love it that you're doing things to upskill your knowledge. And I think they've been very honest that actually the single assessment framework, and in its current format, isn't easily to digest and break down, which is why we're seeing episodes like this trying to do it for you, and many other resources kind of popping up, which is great for us because it's breaking it down, but obviously highlighting to the CQC that gap in knowledge there.
I suppose for me as well, it's a really great tool. If your team get to know what the quality statements are, it's a really great tool to have when we're assessing things. So when we're assessing someone's care needs and we're doing a care review, we can say, right, we're going to do a care plan review today for such and such. After we've done that care plan review, I want us to go through the quality statements for effective, and I want to see whether we feel like we've done enough to meet each of those quality statements in that domain. It's a really great self-reflective tool. Have what I've done today, or has anything that I've done today gone against these quality statements or gone in favor of these quality statements? If it's gone in favor of it, have I documented it? If it's gone against it, have I learned? Have I reflected? Have we done a learning outcome? Because if we're doing that, we're going to hit quality statement 1 of the safe domain, which is learning culture. And then we're going to also make sure that we're developing and we're innovating and our team have the information, etc., 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 etc. So it's a really good way to start actually benchmarking yourself and the work that you're doing as well. Because if you can say to the CQC, well, obviously, I don't know, involving people to manage risks is a huge thing for us here. You've actually said the quality statement in what you're saying, and you've explained how you've met that quality statement. You've got the evidence to do it. So for me, just really, really great and a really easy way to start learning what these quality statements are. And I promise you, you're not going to know them verbatim just yet. But I do believe we will all get to a point where we know these quality statements very, very well in comparison to what we did the Chloe's.
We will indeed. Well, before we close out, next week's show, we're taking a break from these deep dives, but we are sticking with the CQC theme. So we're going to be joined by HCR Law, who were just brought out by Rideouts. But we're going to be discussing CQC enforcement, which I think is quite timely because I think we've seen a number of providers that are currently going through enforcement action. So yeah, definitely one to join us with to get kind of the legal perspective of how to challenge, how to respond, how to support your managers, your teams to remain calm. Obviously, when you're going through that.
I agree. I can't wait to get to the proper meaty quality statements. I know the safe one, the safe domain is a really meaty one. Effective, I find quite easy. You know, when I did the poster, it's one of those where you go from doing like 9 or whatever it is on the safe or 8 on the safe to like for effective is not that much. And you think, well, oh, okay, then caring, another one. I don't think caring is that huge either, off the top of my head. And they're the sort of easy ones. But the things like responsive, the well-led, when we get to that well-led domain, that's going to be a meaty session. That one probably will run up to 2 hours because there is a lot under that well-led, especially under Regulation 17 of good governance, that we really do need to think about. And the reason I want to do well-led last is there's a lot of stuff that feeds from the rest of these quality statements and the other domains into the well-led, where if actually we cannot demonstrate some of our knowledge in these other areas and these other quality statements, there is no chance we're going to get a good in well-led. We're only going to be able to achieve or require some improvement. But that's going to be great when we get to that section. So yes, Mark, really looking forward to next week. I like that we're sticking with the CQC. I think it's a hot topic at the moment. And I'm hoping people are finding this beneficial. Please do go and find those posters on our website. Use them, send them digitally, print them off. There's a load of resources on there as well. And like I say, go and check out Mark's blog post tomorrow and the guides or resources he'll be putting out on Friday as well. Anything before we go, Mark?
Nothing else from me. Make sure you stay hydrated. I would say dehydrated. I was like, that doesn't sound right in my head.
Eat fluids.
Yes. Remember the jelly, tomatoes, all full of water. Zoe has just asked, I'll be able to rewatch this. Zoe, I will share the YouTube link. You'll be able to catch up on YouTube. But yeah, no, nothing else from me. Have a good evening. Enjoy the sunshine and the lighter evenings.
Definitely. Good night, everybody. Huge shout out and thanks to our sponsors, Prosper Well, CBAT, Care Business Associate Training, and Attis Care for allowing us to continue this wonderful journey into social care and elevating, educating, and celebrating all things care. But we will see you next week live at 7:30. So good night. Take care. Eat your fluids.